Good afternoon, students. I hope everyone is well. Today we are going to focus on pulmonary physiology. So what I would like to do is I want to give you my personal class first, and then we'll go through the first aid. Okay. So let's begin. First concept is we're looking at a mathematical equation that we tend to see often. Now I have it like x over y is equal to 1. So what does that mean? That means that if I increase x, I will increase 1, right? Or if I decrease y, I can also increase 1. Okay, well then how do I decrease 1, right? Well, maybe I decrease x or I increase y, correct? Okay, good. This is very important. This is very, very important to remember because what they do is that they just call this your VQ mismatch. That's what they do. They'll call this your VQ mismatch. So with your VQ mismatch, the V stands for ventilation, Q for perfusion, or I put air and liquid. I just find it to be much easier to understand, right? We have air and we have liquid. And again, it is equal to 1. So how do I increase 1? Maybe I decrease Q or I increase V. You see that? How do I decrease 1? Maybe I increase Q or I decrease V. See? It's the same idea. Okay, very important to remember. So this is how we play with this, right? Now, we're going to continue talking about VQ mismatch in a second. I'm going to jump into dead space. I want you all to remember what is dead space. Remember, we have two types, okay? We have physiologic and we have anatomic. What's the difference between the two? Anatomic dead space is an area within the respiratory tract that will not have oxygen exchange. You will not find any oxygen exchange. So areas such as your nose, your mouth, your the trachea, etc. Right, the terminal, all the way down to the terminal bronchioles. There is no exchange of oxygen. So that's called an anatomic dead space. Versus physiologic dead space, that's an area where you do have exchange of oxygen. It's just that for whatever reason, at this point in time, there is less exchange. Why? Usually it's because there's less perfusion, or the other way around, there's a lot of ventilation. So your physiologic dead space is a well ventilated area in the lung with very little perfusion. Okay. Normally, that'll be the apex of the lung. Next concept is minute versus alveolar ventilation. So minute ventilation is basically just your respiratory rate. That's it. How often are you breathing per minute? That's it. But see, the thing is that what is most important is not so much your respiratory rate, rather it's your alveolar ventilation that's most important. How much of that oxygen that you're getting in, how much of that actually makes it down into the alveoli? That's what's important. Okay, so alveolar ventilation versus minute ventilation. Now there's an equation in the first aid. I want you to learn it. But what's more important for me at least is for you to know what it represents. Okay, minute ventilation versus alveolar ventilation. You can have somebody that's hyperventilating, right? Just because they're hyperventilating doesn't mean that they're getting any oxygen down to the alveoli. Can you see? So what if you have a friend who's hyperventilating, right? What would you tell them? You'll say, "Hey, relax, taking a deep breath," right? All right. So now we move down onto the next equation. Again, all I see is x over y equals 1. It's just that they call this one compliance. So compliance is change in volume divided by the change in pressure. What is compliance? I want you all to have this very clear. Compliance is the ability to expand, not coming back. That's elasticity, okay? Recoil is coming back. To expand, that is compliance. Coming back, that's elasticity, that's recoil. Two different things. Please don't confuse them. So compliance, how do I increase compliance, right? Oh, okay. Maybe I take in a deep breath, increase volume. Hey, whenever I take in a deep breath, when I take in a deep breath and I have oxygen diffuse across the alveolar membrane and make it to the pulmonary capillaries, how do the pulmonary capillaries respond to low oxygen? Do they vasoconstrict or do they vasodilate? They vasodilate. When they vasodilate, what happens to pulmonary resistance? Decreases. What happens to pulmonary pressures? Decreases. What happens to compliance? Increases. You see? Okay, so then what will happen if a patient has high pulmonary pressures? I don't know, maybe pulmonary fibrosis because they were taking amiodarone, something like that, right? Maybe busulfan, bleomycin. Well, their pulmonary pressures increase. Boom. So compliance has to decrease, making it very difficult to inhale. Okay. Next concept, FEV1 over FVC ratio. Now, what I always like to ask is, what do they represent? Not what do they mean? Forced expiratory volume in 1 second. Okay, that's great, but what do they both represent, really? They both represent exhale, exhalation. That's what they represent to me. So now here's my question. Who suffers from, who has difficulty exhaling? Restrictive or obstructive lung disease? Obstructive lung disease, right? They have trouble getting air out. O for obstructive, O for out. They have trouble getting air out. So with that being said, yes, with restrictive lung disease, you'll have a decrease in the FEV1, FVC, FEV1 and FVC, thus making the ratio, or rather keeping the ratio normal or just a little bit above normal. But because our patient with obstructive lung disease has trouble exhaling, that's why that's why we need to focus on a decreased FEV1 FVC ratio in all obstructive lung diseases. So my normal ratio is 80%. So if they ever give me anything less than 80%, I immediately jump to obstructive lung disease. If they say normal or high, maybe it's a normal patient, healthy patient, or maybe it's somebody with a restrictive lung disease, but alone it's not enough. But when it's low, it's very diagnostic for obstructive lung disease. Okay. Next one, read index. Read index. So read index is also associated with obstructive lung diseases. What we're seeing here is the thickness of the bronchiole divided by the size of the lumen. So if a patient has an obstructive lung disease, he is going to produce a lot of mucus. And in order to produce a lot of mucus, he has to undergo goblet cell hyperplasia. And if his goblet cells hyperplase, then the bronchioles themselves become extra thick. Boom. And if there's a lot of mucus, what happens to the membrane? It has to decrease in size, thus increase read index in all obstructive lung diseases. Okay. And we're back to VQ. So here's my lung divided into three. I'm sure you've seen a similar image in the first aid. What I want you to see is that we have much more V in the apex than we do Q, and we have more Q at the base than we do V, and they're just about equal in the middle. So that means if I have more V than Q, then the VQ mismatch will be greater than 1. If in the middle V is equal to Q, therefore it's equal to 1, and at the base we have V less than Q, therefore it'll be less than 1, the ratio, correct? So now if I look at the apex, I see that I have an area that has a lot of ventilation and a little bit of perfusion. Does anyone remember what that was called? That's right, physiologic dead space, right? An area that is well ventilated and poorly perfused, okay? Well ventilated and poorly perfused, which means that at the apex of the lungs, that's where I have most physiologic dead space. Nice. All right, good. So what happens if a patient has a pulmonary embolus? Well, if he has a pulmonary embolus, we're going to have a decrease in Q, correct? So if I have less Q, what's going to happen to my VQ mismatch? It's going to increase. What's going to happen to my physiologic dead space? It's going to increase. So does that mean that an increase in VQ mismatch also means an increase in physiologic dead space? Absolutely. Okay, one and the same. What if a patient starts exercising? If he starts exercising, he's going to deliver much more blood to the lungs. And in doing so, we have much more Q. So the VQ mismatch should decrease, or the physiologic dead space should decrease. All right. Next concept. Here we have a respiratory bronchial alveolar duct, the alveoli, and lining the alveoli in yellow is our friend surfactant. So what I want you to understand is that all this together combined, respiratory bronchial alveolar duct and the alveolus itself is considered or known as the respiratory unit. What that represents is this is the area where we do have oxygen exchange. So this is where that alveolar ventilation equation comes into play. Okay, this is what we want. We want our oxygen to cross over or diffuse across into the pulmonary capillaries. So what I want you to notice, though, is that in order for oxygen to do that, he has to first go through the alveolar membrane. That's one layer. Then he has to go through the interstitium. That's 2 layers. Then he has to go through the capillaries. That's 3 layers. What does that mean? Why do I care? because if I have a disease affecting any one of those three layers, oxygen is going to have a difficult time diffusing across. See? And if oxygen cannot diffuse, where is he going to stay? He's going to accumulate in the alveoli, right? Big A. Meaning small a artery is going to have less. So we have much more here, less there. So what do you think is what do you think will happen to what's known as our AA gradient? It should increase. Why? Because we have more A in the alveoli, and sorry, we have more oxygen in the alveoli, and we have less oxygen in the arteries. A nice way to remember the difference between the two, big A versus small a, what's bigger, a lung or a capillary? Well, clearly a lung is bigger, so therefore big A for lung, small a for capillary. All right. Here, what I'm showing is the AA gradient. So the AA gradient is about 10 or so, maybe about 10 to 15. If they ever want you to look for a high AA gradient, they're going to give you a number much larger than 10. It might be 20, 30, 40. Okay. So an AA gradient of 10, what does that really represent? What that says is that if 100 molecules of oxygen were inhaled, how many molecules will have to diffuse across the membrane to therefore give me an AA gradient of 10? Well, I say about 45 would have to cross over, leaving me with 55 in the lungs, and therefore 55 minus 45, I get 10. You see? So essentially, the general idea is whatever arrives to the lung, of that amount that arrives to the lung, just about half, almost half, has to diffuse across. You see? Half or just about, close enough to half. That's what I want you to understand. Now, let's get into the profiles. With a restrictive lung disease, the patients have trouble getting air in. That means that if they have trouble getting air in, their O2, PaO2, small a, arteries, will be low. And if their O2 is low, how would their lungs respond? They will hyperventilate. And in doing so, by hyperventilating, you will lose CO2. I want to make sure we all remember that whenever you see the word ventilation, yes, although we understand that the concept of ventilation is the exchange of oxygen with CO2, whenever you see ventilation, I want you to always remember CO2. It's more associated with CO2. Whenever you see diffusion, that's more related to oxygen. So what are we trying to do with CO2? Do we want to keep it or do we want to get rid of it? We're trying to get rid of it, right? So if I hyperventilate, I hyper get rid of it. Got it? So therefore my CO2 has to be low. And because CO2 is an acid and I'm hyperventilating and I'm losing acid, I stay base. So respiratory alkalosis will occur in restrictive lung diseases. Here's another thing. If oxygen cannot diffuse across, then how will the pulmonary capillaries respond? Will they vasodilate or will they vasoconstrict? They will vasoconstrict. And why vasoconstricting? Well, vasoconstricting pulmonary resistance and therefore pressures will increase, causing a right ventricular hypertrophy, also known as cor pulmonale. So, in restrictive lung diseases, we have diffusion problems, right? Because oxygen can't get across. We have the pulmonary capillaries, they respond by vasoconstricting, and therefore there is less perfusion. So we have a diffusion problem first, and then a perfusion problem. Meaning, if I ever see diffusion and perfusion problems, they are more likely associated with a restrictive lung disease, 90% of the time. That being said, we also have a non-productive dry cough that's associated with restrictive lung diseases. This is all 90%. It's not 100%. Everything I say is 90% or more, but never 100%. They always change it up. There's always going to be a new disease. Okay, but this will help. So if we have a non-productive dry cough, why do we have a non-productive dry cough? Because usually the interstitium is what's affected. Okay, the interstitium, not the airways, like in an obstructive lung disease. The interstitium. That being said, if the interstitium is affected on chest x-ray, what do we see? A reticular pattern, a nodular pattern, or a reticular nodular pattern. Okay, they'll give you something like that, or maybe ground glass appearance. Okay, they might give you that too. Typically, we have non-bacterial or like viral fungal diseases or infections rather, and or atypicals. All right, atypicals would all cause infection. So basically anything that's not a bacteria all lead to restrictive lung diseases, correct? Such as sarcoidosis, tuberculosis, aspergillosis, histoplasmosis, coccidioides, blastomycosis, you see? Okay, so, and another thing. So these patients with restrictive lung diseases, they also tend to lack surfactant. which we'll get to in a second. I want to mention something about surfactant. So if I don't have any surfactant is going to allow for compliance. It's going to permit that to happen. So if I don't have any surfactant, then I won't be able to expand. So I collapse, and therefore, every time I inhale, my alveoli have to pop open, and every time they pop open, you hear a crackling sound. So remember, crackles as a buzzword for restrictive lung diseases. Okay. Now, with surfactant, if I could just come back here, what does surfactant do? Surfactant, I think of it as like oil, right? Oil around, let's say my fist, right? This is my fist is my alveoli. And if I were to wrap a bunch of oil around my fist, correct? What would happen if I were to try to grab my fist with my other hand? It'll make it very difficult, correct? It'll make it very difficult because I have all this oil, makes it very slippery, right? Okay, so my fist represents the alveoli. My hand trying to grab it represents atmospheric pressure. So atmospheric pressure is always trying to compress and collapse the alveoli. Surfactant doesn't allow that to happen, which is a good thing. So surfactant allows for compliance to ensue. However, if you ever are lacking surfactant, maybe a child was born too early, premature, and therefore he lacks surfactant. Or maybe the patient had some sort of pancreatic disease, like a pancreatitis, where all his digestive enzymes came up to the lungs and started eating away this surfactant. Same thing. Maybe the patient had congestive heart disease, and we had all this fluid buildup and wash away the surfactant. The point is the surfactant is gone and therefore causes ARDS, which is really just a restrictive lung disease. Okay. All right, so we come back. Now, with obstructive lung diseases, these guys, O for obstructive, O for out. They have trouble getting air out. Their respiratory rate usually tends to be low. They're usually hypoventilating, and for that reason, CO2 is high. And again, because CO2 is an acid, we have respiratory acidosis with obstructive lung diseases. Again, ventilation problem. It affects the airways. Because it affects the airways, remember our read index? We're going to have a lot of mucus, right? Mucho moco, right? A lot of mucus. It is a productive cough, right? What's it called? The current jelly, sputum, rusty colored sputum, yellow sputum, green sputum. It's all productive, right? We have goblet cell hyperplasia, and on chest x-ray, we're going to have hyperinflated lungs with a flattened diaphragm. That's very straightforward. Please make sure you know what that looks like, okay? And again, many bacterial infections usually will cause obstructive type lung disease like strep pneumo, Klebsiella, H. influenza, Neisseria, etc. All right. A couple of buzzwords for him would be rails and rhonchi. All right, the next concept I want to discuss is hemoglobin saturation, desaturation. Okay, so let's say here I have a red blood cell. This red blood cell tends to have 4 spaces available for oxygen. Now, every now and then we have hydrogen ions. They come around. They tend to be bullies. They say, hey oxygen, get out of here, man. This is my red blood cell. Okay, fine. So what happens is that when oxygen leaves, they are now replaced by hydrogen. So we have hydrogen ions here, replacing. I just put another one right over here, and another one just over him right there, replacing the oxygen, which has now desaturated. Okay, great. This is known as my Bohr effect. Okay, when I am desaturating oxygen. Why am I desaturating oxygen? Because we have hydrogen or acid, right? We're in an acidotic environment. It's causing desaturation. And why do we desaturate? Because we're trying to provide oxygen to the tissue, correct? All right. Well, what if it was the other way around, right? What if I said, all right, well, we've given enough oxygen to the tissues. Now it's time to put the oxygen back in place. So if that's the case, then we just replace the oxygen. And when we replace the oxygen, we actually kick out the hydrogen. And when we kick out the hydrogen, this is known as the Haldane effect. Okay? So when I desaturate oxygen, Bohr effect. When I desaturate hydrogen, Haldane effect. Why do I desaturate oxygen? Because hydrogen is pushing him out. Why do I desaturate hydrogen? Because oxygen is pushing him out. Okay? Which leads me to the hemoglobin desaturation curve. Once again, what do I see? Red line is normal. Red line represents from from point one to point two. What is happening? I am losing oxygen, correct? I am desaturating oxygen, i.e. Bohr effect. From point one to point two, I am desaturating, correct? Great. But as I desaturate, who's taking the place of oxygen? Hydrogen. So from point one to point two, I am losing oxygen, but hydrogen is taking his place. All right. What about from point two up to point one? Well, from two upwards to point one, I am saturating with oxygen, right? Because I am now oxygenating my hemoglobin molecule. But at the same time, as I oxygenate, I have to release hydrogen. So I'm desaturating hydrogen from two to one. Okay. I want you to notice over here on the side, I spelled Haldane, H for Haldane, right? And the O in Bohr, I want you to put O2. So you can remember Bohr is associated with desaturation of O2. Now, again, what causes right shift? I'm sure we've seen this in previous videos. It's cadet, C-A-D-E-T. They all causes right shift. Okay, an increase in CO2, altitude, DPG, exercise, or temperature, which all of this eventually causes an acidotic environment. Again, will all lead to a desaturation and therefore a right shift. So what causes left shift? The opposite. So if an increase of these, right, if an arrow going up causes left shift, right shift, then you just decrease it, right, and that'll cause a left shift. Okay. And here on this image, I'm sure we've seen this graph before, where we have pulmonary pressures, intrathoracic pressures rather, and as we inhale, I for inhale, we can see that the pressures become more negative, and as we exhale, we can see that the pressures become more positive. So then if I wanted to show you a patient with a restrictive lung disease, I say, oh yeah, restrictive, they can't get air in. So I do this. I say, oh, they have very little air getting in. But do they have any trouble getting air out? No, they have no trouble exhaling. So it'll basically just be like a small egg. You see? That's a restrictive lung disease. Say, okay, great. Then they'll give you many causes for it: pulmonary fibrosis, maybe some sort of infection, whatever. What about obstructive lung disease? Well, in obstructive lung disease, they have trouble getting air out. So for the most part, they don't really have an inhalation issue. I'll just kind of leave it there. But they do have issues exhaling. So you'll see something like this. And that would be representative of an obstructive lung disease. But what if you see a patient that looks kind of like so? You see something like this, and immediately your brain says, oh, that has to be restrictive. And then they give you this. And you say, oh boy, that looks obstructive. That looks restrictive and it looks obstructive. Who has that problem? What is the only disease that's restrictive and obstructive in nature? Emphysema. Okay? He presents as an obstructive and a restrictive lung disease. In emphysema, we have trouble exhaling, obstructive. But in emphysema, we also have damage to the alveolar membrane, making it very difficult for oxygen to diffuse across. You see? And that is my class, everyone. I hope this was helpful. Thank you for your time. I will see you soon. Have a great day.